Okay, we're moving on now, and we're going to talk about the topic of arteriosclerosis, which is a topic you may know better as hardening of the arteries. But before I start talking about hardening of the arteries, I want to talk about how blood vessels in general, whenever they're injured, repair themselves, because the mechanism by which they do this is sort of a repeated theme that we're going to see occurring during the process of atherosclerosis and arteriosclerosis, which, by the way, are two different things, and we'll learn about both of them. Okay, so if a blood vessel is injured, the process by which it undergoes healing is very similar to the types of processes we've learned before for healing. You'll remember earlier in the semester when we learned about the process of healing, it was primarily fibroblasts that were responsible for doing things like secreting collagen and other types of extracellular matrix proteins to help repair and form granulomatous tissue, etc., and to form scars. Well, there are no fibroblasts in a blood vessel. And remember, a blood vessel is made of three different layers, or three different tunics. There's the tunica intima, that's the innermost layer closest to the lumen, where the blood flow occurs. There's the tunica media, that's the layer where the smooth muscle tissue is located that contracts for vasodilation and vasoconstriction. And then there's the outermost layer, the tunica externa, which is principally connective tissue. Now, because a blood vessel doesn't have fibroblasts to promote the healing process, it uses instead smooth muscle cells, and the smooth muscle cells it uses are located in that tunica media. Now, if you look at the intersection right between the tunica media and the tunica intima, there is a layer of smooth muscle cells right in that junction that do not necessarily have contractile properties. They don't contract as much as they have the ability to undergo mitosis, and they have lots of rough endoplasmic reticulum, Golgi apparatus, etc., so that they have an ability to manufacture matrix when necessary. And these are the principal guys that if the tunica intima, the innermost layer of the blood vessel, gets damaged, they will migrate from the tunica media into the tunica intima, and you can see some here that have migrated in, and they will actually then begin the process of healing and repair. And they'll do that, of course, by producing things like extracellular matrix proteins. They'll undergo mitosis. This typically causes, as you can see in this picture, thickening of the intima. Normally the intima is very narrow or very thin, like it is over here on the normal side. Over here on the repaired side, it's much thicker due to the migration of these smooth muscle cells into the area and their activities. And we'll see more about this later on, but this is kind of the underlying premise behind the formation of atherosclerotic plaques. So before we start talking about the details, I need to define a few terms for you. This whole part of the lecture is on arteriosclerosis. And arteriosclerosis is sort of a global generalized term that's used to refer to any type of abnormal thickening and hardening of blood vessels. And when we say abnormal thickening, we're talking about the tunica intima, that innermost layer that thickens. And of course, if the tunica intima thickens, if we're looking at a cross-section of a blood vessel, and the tunica intima thickens up, that, of course, is going to reduce the overall size of the lumen. And when I reduce the size of the lumen, of course, that's going to impede blood flow, and it can lead to things like ischemic events. There are different types of arteriosclerosis. Your book mentions 3. There's only 2 that I'm going to ask you to be concerned with, because really only 2 of them have any sort of clinical, pathological importance. The third one's kind of a silent one in the sense that it really doesn't cause too many symptoms or problems. So the 2 I'm going to, the 2 I'm going to ask you to focus on are arteriolosclerosis and atherosclerosis. And I want you to be very careful to note the spelling differences between these 2 and to be very careful in your distinction between them, because they are distinct and separate diseases. These are both subtypes of arteriosclerosis. The first one, arteriolosclerosis, is when small arterioles, those are the small arteries, end up thickening. and the walls thicken up substantially. And I'll show you some pictures of this later, but this is pretty much a condition associated with chronic or long-standing hypertension. Oftentimes the hypertension is associated with diabetes, but not always. Sometimes people can have what's called a chronic essential hypertension or malignant hypertension that doesn't have its underlying foundation in diabetes. The other type of arteriosclerosis we're going to talk about is atherosclerosis, and I'm going to use the abbreviation AS, capital A, capital S, for atherosclerosis. Atherosclerosis is the most common type of arteriosclerosis. It usually involves larger arteries, things like the aorta or the carotid artery, circle of Willis, arteries in the legs, for example. And this involves a formation of an atheroma. And an atheroma is that plaque-like structure. In Greek, atheroma literally means gruel. And the reason for that is if you look at the interior of these plaque-like structures that form on the tunica intima blood vessels, it really does almost look like oatmeal or gruel. So these are the two types that we're going to be talking about. I'm going to focus most of my time and attention on atherosclerosis because it's far more common. Before I start talking about the pathogenesis, so let me just spend a couple minutes talking about some things like risk factors for atherosclerosis. And by the way, these are also risk factors that are associated with ischemic heart disease, because typically if one develops atherosclerosis, over time they will eventually develop ischemic heart disease as a result. Very common pathway there. So we can divide out risk factors into what are called constitutive risk factors and modifiable risk factors. Constitutive risk factors are those risk factors that you cannot do anything about. There's nothing you can do to alter or change them. One of them is age. The older you get, the more at risk you are of developing atherosclerosis and thus ischemic heart disease. Being male. Women have a protective effect associated with estrogen levels in their body, and as long as a woman is premenopausal, her risk of developing atherosclerosis and ischemic heart disease is much, much less than a comparably aged male. After menopause, when estrogen levels drop off, however, the level of risk for women developing the disease is similar to a similarly aged male. And of course, genetics. If you're born with particular genetic makeups that make you, for example, have high cholesterol levels in the blood naturally, you're going to be at an increased risk, and there's nothing that we can do about your genetics. Now, modifiable risk factors are those that, just as the name implies, are changeable. These are ones that maybe through drugs, diet, exercise, lifestyle modifications, we can lower or reduce so that we minimize the risk of developing atherosclerosis or ischemic heart disease. Hyperlipidemia is one. This means high levels of lipids in the blood. In particular, hypercholesterolemia is really the most important factor that can contribute to atherosclerosis. Cholesterol accumulation inside atheromas is a biggie. So the higher the levels of cholesterol in the blood, the higher your risk of developing atherosclerosis. Hypertension is another risk factor. We're going to learn why shortly, but briefly, the higher your blood pressure, the more shear stress the tunica intima is under, and that means that there's more opportunities for damage to the tunica intima to occur. And once damage is done to the tunica intima, that sets up the opportunity for the formation of an atheroma. Smoking, of course, is a risk factor for a number of reasons, not the least of which is it contributes to hypertension. There's other reasons why as well, but that's the only one I'm going to mention. Diabetes is a huge risk factor. People with diabetes are at double the risk of developing atherosclerosis when compared to non-diabetic, similarly aged people. And C-reactive protein levels are another modifiable risk. C-reactive protein is a protein that's a measure of levels of inflammation in the body, and it's a protein that's present in the blood. The higher the levels of C-reactive protein in the blood is an indication of more inflammatory events going on in the body. We're going to see that inflammation plays a huge part in the development of atheromas. So if physician measures a person's C-reactive protein levels, they can get sort of a potentially indirect measure of the likelihood of that person developing atherosclerosis. Now, all of these are modifiable either by being controlled through drugs, diet and exercise, like diabetes, hypertension, hyperlipidemia. Smoking can be, people can quit smoking, that reduces their risk. And you can even reduce your levels of C-reactive protein. This graph down here shows you how the correlation between levels of C-reactive protein and your relative risk of developing atherosclerosis. And this is based on the Framingham Heart Study out of Massachusetts from several years ago. And you can see that higher levels of C-reactive protein definitely increase the risk of developing atherosclerosis and ischemic heart disease. Now, there's other potential or probable risk factors that the jury is still a little bit out on, but for the most part, they're kind of accepted as, yeah, these are probably risk factors too, and as much as possible should be modified. Those include low physical activity. People who don't exercise are at greater risk. Being obese, living a life of stress, and as I mentioned before with women after menopause, low estrogen levels also contribute to the formation of atheromas. Now, this graph down here is very interesting because what it shows you is that there's a multiplicative effect of these different risk factors. If you have one risk factor, your risk is at a certain level. If you have two risk factors, your risk doubles. If you have three risk factors, your risk goes to 9 times. So the more of these risk factors, which are listed down here, you add, the higher the probability of a person in 10 years' time developing atherosclerosis. So let's talk about the pathogenesis of atherosclerosis. This is a multi-step process. There's a lot of different events that happen. And what I want to emphasize first here is that we're operating under the assumption that the endothelial injury hypothesis is the correct hypothesis for the pathogenesis of atherosclerosis. Endothelial injury hypothesis. This is the most popular hypothesis right now to describe how atheromas develop in the first place. Just know that there are other competing hypotheses, and research really hasn't clarified which of these is the correct hypothesis. And personally, I suspect it may be a combination of several of these hypotheses together. But we're just going to operate under the theory that the endothelial injury hypothesis is the hypothesis describing the pathogenesis of atherosclerosis. Here's how it goes. Initially, there is some sort of an inflammatory response. Okay, so up here we can look and see here's a normal, healthy cross-section of a blood vessel, your tunica intima, your tunica media here, and your tunica externa out here. Now, probably the more common way that injury can be induced is through some sort of hemodynamic process. And what I mean by that is that the dynamics of blood flow itself can sometimes damage the tunica intima, particularly at locations where there's a off-branching. So if I have a blood vessel here and then I have a smaller blood vessel that branches off, this is called an ostia, that hole where the breaking off occurs. And at that location, there is greater mechanical shear stress because the blood is separating off and going in a different direction, and it's slamming against the walls of this side route. Those are in places where we believe endothelial damage can occur. Maybe a few of the endothelial cells get knocked right off the endothelium, and the underlying collagen and smooth muscle tissue gets exposed. Other ways that injury could be induced, sometimes certain chemicals like tobacco can cause denudation or the removal of endothelial cells. Some people suspect hypercholesterolemia can cause that kind of damage. Sometimes immune complex deposition, like the formation of AGEs that are in diabetics, or the formation of immune complexes in certain types of autoimmune diseases, can also damage the blood vessel, as can radiation and perhaps some different types of bacterial infections. Whatever the cause, once I get damage to that endothelium, a chain of events is going to occur. For one thing, we're going to get loss of antithrombotics and vasodilators. In other words, the ability of that part of the endothelium to prevent a blood clot from forming is going to be lost. Those endothelial cells tend to secrete prostacyclins, and prostacyclins act like a type of Teflon. They kind of provide sort of a slick surface for the blood to skim by on. And once those endothelial cells are lost, we lose that slick surface, and so a blood clot can potentially form. Vasodilative properties are lost, and so the blood vessel may begin to constrict, and that too can contribute to the formation of a thrombus or a blood clot. Now, once I've got exposure of this endothelium, and I've got loss of those antithrombotics, the first thing that's going to happen is I'm going to start to get release of inflammatory cytokines from the damaged tissue. So things like tumor necrosis factor alpha gets released, interferon gamma, interleukin-1, ROS. Those are all going to start getting released by those damaged cells. And of course, we know what happens when you release these kinds of chemicals. These are all very chemotactic to things like macrophages. And so we start to see an accumulation of monocytes first, because they're monocytes in the blood, and those monocytes then begin to migrate out of the blood into the area of damage, and they transform into macrophages. Also, you're going to start to see an accumulation of platelets, of course, because we've lost our antithrombotic properties. And you're going to start to see the accumulation of lipoproteins, things like LDL proteins, which is the bad kind of proteins. HDL proteins don't tend to accumulate there, but cholesterol and LDLs do. Okay, keep going here to the next set of steps. So, we've got these monocytes. They've been attracted to the area. They've been chemotactically drawn to the area. They've transformed now into macrophages. They're located in this kind of underneath the tunic, what's left of the tunica intima, but above the tunica media here. So they're right in this area here. And those macrophages are going to start doing things like releasing their own free radicals. And those ROS, those reactive oxidative species that macrophages are releasing, have a negative impact on the lipids that are accumulating in the area because it causes those LDLs to become oxidized. Once those LDLs become oxidized, the macrophages begin to consume them. And as the macrophages consume those oxidized LDLs, they get filled up by those macrophages. And those macrophages eventually get so full of these oxidized LDLs that they become what we call foam cells. So here's my foam cells here. And at the same time that that's going on, remember I told you that the way that a blood vessel repairs itself is that some of the smooth muscle cells migrate into the tunica intima? Well, that begins to occur. So here are my smooth muscle cells. They've migrated into the tunica intima. They started doing that up here. They too have the ability to consume some lipids, and they can even become foam cells themselves. But these smooth muscle cells begin to accumulate. They get recruited into the area. They begin to undergo mitosis of smooth muscle cells. And they begin to secrete all kinds of extracellular matrix proteins, things like collagen. That's all part of that repair process, remember. And at the same time that this is all occurring, lipids will, as long as their lipid levels are high in the blood, lipids will tend to continue to accumulate in this area. And that lipid accumulation can lead to kind of a lipid core developing in the middle of the what's now called atheroma. Now you can also, at this point, this is chronic inflammation. You're not only going to get macrophages, you're probably going to get some lymphocytes also migrating into the area. When we were up at this stage here, before we had a fatty core develop, this was called the fatty streak stage. And fatty streaks are very commonly seen in all of us. In fact, even infants have fatty streaks. Fatty streaks produce more oxidative radicals, and that can damage the blood vessel walls further. And it's hypothesized that fatty streaks may be the precursor event to the development of an atheroma. Not all fatty streaks will develop into atheroma. Some of them disappear, some of them remain stable, but some of them, it's hypothesized, do contribute to the development of this atheroma or gruel-like structure. Okay. So now we've got this fatty core. We've got this fatty streaked form. We've got these smooth muscle cells present that have migrated into the area. Some of those smooth muscle cells will actually migrate over top of the atheroma. And they, once they have migrated over the top, they form kind of what's called a fibrous plaque. Or a kind of a cut, because they're able to secrete those extracellular matrix proteins, right? So they begin to secrete collagen. And what they're really trying to do is to cover over the area of inflammation, to kind of tidy up the area and sequester it off from the blood so that all of those foam cells, those macrophages, lymphocytes, other smooth muscle cells, oxidized lipids, necrotic debris from the damaged tissue in the first place, all of that gets sequestered off by the formation of this fibrous plaque. And this fibrous plaque, by the way, is what partially contributes to these high C-reactive protein levels that are indicative of inflammation. Now, fibrous plaques can be of two varieties. They can be stable or they can be unstable. Stable means that they don't change over time. They remain relatively unchanged. Unstable plaques are ones that have the ability to rupture, and maybe this whole plaque area tears off. When that happens, that can lead to a catastrophic event in terms of the formation of a huge blood clot, and this can lead to ischemia, and in some cases it can even lead to death. So a ruptured one can lead to the formation of what's called a complicated plaque. These are plaques that maybe after the thrombus or after the blood clot forms and maybe is cleared out, you get a more complicated plaque in terms of maybe the fat begins to become calcified with calcium, for example, and it can become very hard and friable, meaning that it breaks apart very readily, which is not a good thing. So what do some of these atherosclerotic plaques look like? Well, here you go. Here's a cross-section of a blood vessel. Here's the lumen. The lumen normally would have been about yay size, but because of the presence of a fibrous plaque, here's the fibrous plaque, and over top of a cholesterol or lipid core where there's lots of necrotic debris, we get this very much reduced in size lumen. You can see the lumen is much smaller than it used to be. I'm not going to worry too much about these other pictures up here, but this one does a nice job of showing you what those plaques look like. And what are some of the outcomes for an atherosclerotic plaque? Well, atherosclerotic plaques normally can be clinically silent, if you will. And what I mean by that is they're not going to produce any symptoms until you get some sort of a unstable plaque that ruptures. So in the preclinical phase, you can have a normal artery. Sometimes you get fatty streaks develop. Sometimes those fatty streaks resolve. Sometimes they move forward and become what's called a fibrofatty plaque. And eventually that plaque may grow in size as more lipids accumulate in there. And it's at this point that a stable plaque can rupture, can become an unstable plaque. And that's when we can get things like rupture out of the side wall of the blood vessel, which would lead to aneurysm. You can have rupture of the plaque that leads to the development of a thrombus, so you get occlusion. Or you can have the plaque continue to grow in size so much that it more or less completely occludes that lumen just by sheer size. Now, I told you that there was another type of, let's see here, whoops. We don't want to go that way, we want to go the other way. I told you that there was another type of atherosclerosis or arteriosclerosis called arteriolosclerosis. And again, this is only involving small arteries, and again, I just want to emphasize that that one's associated with hypertension. You don't get the formation of plaques, you just get thickening, severe thickening of the blood vessel wall to the point where the blood vessel wall thickens so much the lumen size is much reduced. Again, we see this with different types of things like malignant hypertension, with diabetics who have hypertension, etc. I think that's enough for now on atherosclerosis. Next up, we're going to talk about ischemic heart disease, which is the progression from atherosclerosis.